Welcome to Innersight, Health Optimization with Rudy and Shaun.
Right, Shaun, here we go. Podcast number 28. It's most of the stuff we've known or we've chatted about so far, we knew enough about to be able to talk with. But today is different.
Yes, absolutely. So today we're going to talk about some oral health stuff. And basically, recently we've seen more and more information in the media regarding oral health and the association with dementia and heart disease and things like that. And for us in a longevity practice, that's quite important. So who better than Johann Lochner to help us with the subject today? So Johann is in private practice in Somerset West, and he's going to help us out today. So Johann, can you maybe introduce yourself and just give us some background and tell the audience what you do for a living?
Yeah, thanks for having me here in Cape Town. Must say it's a first for me to be part of a podcast, so let's see how it works and how it runs. So yes, I'm a qualified dentist, and then we specialize in oral medicine and periodontics. The oral medicine part is broadly your dermatological problems that you find in the mouth, like on any type of skin or mucosa. And then we do the periodontics part, which is basically gum disease, and that's what you guys are interested in. So I'm going to call it gum disease in layman's terms. We're going to talk about gingivitis and periodontitis. And then the other part of my speciality is the replacement of missing teeth with implants, where needed bone augmentations, where needed gum transplants or augmentations and so forth. So yes, I do all three parts of my speciality, and let's see if I can help you with the periodontal health part and those associations with general health.
So you started out in South Africa, but then you moved abroad for a while, and you worked a bit in the UK, as far as I know.
Yeah, I had to pay a student loan.
So, like us all.
Like us all. We all went that route.
So yes, qualified in 1996, and then I did an 8-year stint in the UK. And at that time, I also followed a structured training program in the UK, wanting to specialize in periodontics from quite an early stage in my career. So I did the programs in the UK and was a member of the British Society of Periodontology from quite early. And like I mentioned earlier, I mean, as early as 1998, there was one of the biggest congresses I've ever attended at the time was in Glasgow with the British Society of Periodontology. And already at that stage, the association, especially with cardiovascular diseases and pregnancy-associated complications, was already then well researched by Offenbacher. And it's quite interesting. I mean, nowadays, if you open a magazine, the first thing you would see is your oral health will give you Alzheimer's or dementia. But the association with heart attacks and stroke and these things have basically been there for over 20 years.
Yeah, I want to move back that so we can bring our listeners in. So for us, we read that now as longevity doctors, and we're like, okay, you have to know about the mouth, but I don't know if our listeners knew, but heart disease, strokes, diabetes, and also dementia, all have some type of connection with the mouth, and we were not really taught that at medical school, but it is picking up. And Shaun, you did a bit of a search. I mean, since 2024, there's been loads of publications about that.
Yeah, I think it's come to the front now recently. But Johann just mentioned that they talked about it in 98 already. So these things sometimes take some time to reach the population base, to get the message out there. And I think we're now at the point where you read it and you start to wonder, okay, but what is this oral health and heart attacks? What is the association? So the message, I think, is getting out there at the moment. And that's why we're here today, because I don't know much about dentistry as such. I make your patients sleep sometimes, but that's the end of the equation. I don't know anything about the dental health side, and I think that's going to be an interesting discussion today.
Yeah, I mean it's very very strongly linked with basically an inflammatory response, and like so many things we see nowadays, the connotation with a hyper inflamed immune system, being it with a systemic inflammation. So in essence, that is what periodontal disease causes, because it's caused by bacteria, and that causes a hyperinflammation. Then obviously that spills over into the bloodstream and to the whole system.
Yeah, and I think in aging and longevity, this is saying what we call inflammaging, which is basically a process of inflammation driving this aging process. So it fits in nice with the whole theme of the inflammation process. So cardiovascular disease is probably the first one that they.
Yeah, the main ones at that Congress was definitely the cardiovascular disease, but that encompasses a few things. I mean, obviously heart problems like your atherosclerosis, which basically gives heart attacks with the plaque formations. And it's not only about the hyperinflammation. I usually say to patients that in layman's terms, your blood becomes sticky. But there's also hyperinflammation. And then the plaques that you get within the arteries, these bacteria that are associated with gum disease, specific ones, are found in these atheromas. I mean, they can be grown from the plaques. So they live in the plaques, they cause the hyperinflammation, they make the blood sticky. and there you have a problem. But and that, in a way, that is pretty much the thread that you get with the associations with all the problems you get. So the inflammatory cascade, being it with cytokines, interleukins, that whole inflammatory cascade, and then the direct bacterial toxins, bacteria present physically in the plaques or in the areas that's affected, and there's your problem.
So we've established that there's a correlation between oral health and these medical conditions.
Or even stronger, maybe a causation.
Now, that's the question. And I think I've recently read something that they're even thinking of doing like a vaccine to try and prevent certain of these oral health bugs getting into the arteries and causing problems. But let's step back a little bit and let's start from the beginning. Let's just start with your field. So what is gum disease? Where does it start? Tell us a little bit. What can we do and things like that?
Yeah, listen. Gum disease is basically the biggest cause of tooth loss that you get in the population. Obviously, you have caries, okay, which is tooth decay. We're not talking about tooth decay today. We're talking about gum infections. So more than 90% of the population has some kind of gingival or gum problem. Okay, 90% of us. Fortunately, that is not all severe gum disease that's going to give you all these associated systemic health problems. That's just a gingivitis. So a gingivitis is basically bleeding gums, okay, but not the severe kind. So I have to distinguish between a gingivitis and a periodontitis, which is the one that you don't want. But with everything, if you have the one that you don't want, there's ways that we can manage it. We'll talk about that. But the gingivitis, not so harmful, and it affects the gums, where your periodontitis affects the gums and it affects the underlying supporting tissue, which is the bone. And the late effect of periodontitis would be then damage of the gum, which goes over to damage of the bone, which gives you loose teeth in the advanced stages, and then you would lose the teeth.
Is it two completely different diseases, or is it a slow progression from gingivitis to at the end of losing teeth? I
think I'm going to try and make it simple, and we'll take the ones that start with gingivitis and then progress to periodontitis. Okay. There are various amounts of different types of gingival and periodontal diseases. I think let's stick to the main line because there are ones that progress that doesn't progress, that basically starts off being immediately destructive in nature. Okay, your more aggressive types. But for most, it will start off with somebody that has a gingivitis, so bacteria form on the teeth, dental plaque, sits on the teeth. In the normal diet that we have, it will calcify. I always compare it to the inside of a kettle. If you boil that new kettle enough, it has a bit of chalk on the inside. So what happens is the bacteria, which is soft initially and can be easily brushed off, calcifies and it becomes hard. And there is the interesting part. Not everybody that has bacteria on their teeth that calcify, so firstly plaque or calculus, will get periodontal disease. Unfortunately, there must be a susceptibility, and that is your genetic component. So you can have awful oral hygiene. I mean, you cannot brush your teeth for months on end and you will not have periodontal disease. You'll have gingivitis. You'll have bleeding gums when you brush your teeth. You might have a bit of a breath issue that might not look that good, but it will not necessarily progress then to bone loss and the tooth loss part. That's a very complex. Immune mediated response. But that, in a way, is what affects your patient that has the systemic health issues. It's obviously a very complicated cascades of inflammation.
Amazing.
Yeah.
So taking it back to someone sitting at home, because you said 90% of us do have it.
Yeah.
And
as gingivitis.
Yeah. And how do they know it? When they floss, they have a little bit of bleeding, or how do you see that?
I mean, obviously, when I look at somebody, I don't necessarily look straight at their gums. Okay, but it's very easy for a professional to see the problems. But yes, it's a difficult one for the person there in the street. The first thing would be that if you brush your teeth and you spit out in the basin, that you will see blood. Mixed with the toothpaste. There will be blood when you brush your teeth. It might be very little in the beginning, or it might be a lot. I mean, it can also be an ulcer that you've nicked, or a blister after a nice hot pizza that you've burned. So that's not that, but a persistent bleeding when you spit out and you've brushed your teeth. Obviously, also when you floss your teeth, there will be blood on the floss. So that is important to recognize. And then when we obviously, a lot of us live with somebody else. I mean, if you look at your partner and if you look at their gums and they smile and the gums are visible, the gums would look red. They won't look nice and pink and sharp. They will look like more puffy or rounded and red and swollen. And then halitosis. I mean, that's one of the signs of having a gum problem that's maybe progressing a little bit at that stage already. Very few people with gingivitis necessarily have halitosis. But periodontal patients that's got periodontitis, you can already have a little bit of a smell there that you can pick up.
Okay.
And from a management point, just on the gingivitis, do they need to go to the dentist? Is there something they can do at home? Or
it's not something that you can Google and go on a YouTube video and buy some instruments. I suppose you can. No, don't do that. I mean, it's that old cliche. How often do you need to see the dentist? And it was always you have to see the dentist every 6 months. I don't think one needs to be as rigid as that. You get different risk profile patients, and some patients don't need to go and see the dentist that often. But if you are a patient that had a few cavities in your mouth, if your mouth bleeds, go and see the dentist primarily first. And if you're too scared of the dentist, in my view, go and see at least a hygienist, which will already then channel you then to say, okay, yes, go and see the dentist. And we do see patients, oral medicine specialists, oral medicine and periodontist specialists like us, we do see a lot of patients that say they've gone online, they've done a search, and they found that our profession the periodontists are the people they need to see. Their gums are bleeding, so they make an appointment straight away and get in touch with one of us. But of the patients that have gingivitis, only 10% of the population has the severe periodontal disease, which is your periodontitis. So yes, it's actually quite a large number. I mean, if you think of something that affects 10 to 15% of a population, that's
a lot of people.
It's a lot of people.
And for you to make that diagnosis, can you see it, or is it an X-ray, or what is the? How do you make the diagnosis the next step between gingivitis to periodontal disease?
That is a question that I haven't thought about anybody would ask me, but that's such an important question. So we get a lot of patients that come in and they say, Doc, I've seen my dentist now for 20 years. I've gone 6 monthly, old cliche, for my checkups, and now you're telling me I'm going to lose 6 or 8 teeth and I've got severe periodontal disease. Why was it not picked up by the dentist? Why was it not picked up by the hygienist? And the reason is you have to physically go and search for it. So you don't need expensive methods to diagnose. We basically measure the space and depth of the gum around the tooth. We call it probing. Okay, it's not very pleasant, especially if your gums are sick. Then it can be sensitive. But in essence, it's a little probe or a measuring tool. Looks like a little wire with markings on it, and it's marked off in millimeters. And if the depth of the gum around the tooth exceeds a threshold of 3 millimeters, then you've got signs of periodontal disease or periodontal breakdown. When those measurements are between 1 and 3 millimeters and the gums bleed, that's where we diagnose it as a gingivitis. But as soon as those measurements become more, it is a sign that there is already some breakdown of the soft tissue around the teeth, and then early breakdown of bone that will give you these pockets. And these pockets are basically it's the little grooves around your teeth. I mean, where you plaster floss in and where you brush your teeth. But if those grooves are shallow, you're cool. If those grooves are loose and big, they're full of bugs. They're full of bacteria. I mean, soft bacteria and the calcified ones. So you need to go and look for it. So if your dentist or hygienist doesn't pick up a measuring probe, we've got a sequence that we are taught to examine the patient. So we first do a screening on a few teeth, and if we find on those specific teeth problems, then we do what we call a full mouth periodontal probing. So every tooth is measured in 6 areas. Okay, front, middle, and back on the lips and on the tongue or palate side. So yeah, you have to measure them, and that is where a lot of periodontal disease falls through the cracks. Unfortunately, there's a lot of practitioners that don't do that as part of their general oral examination, but it's important to be done.
So let's say someone is brushing their teeth twice a day and they see blood for the first time, let's say on Monday.
Mm-hmm.
How long must they wait if they see blood for 2 weeks or a month or 2 days? Where must they go and see the dentist? Because, I mean, we've all seen a little bit of blood maybe once and then it's gone. So where do you draw the line? What would your advice be for our listeners out there?
I would at least go and see a dentist once a year. Okay. If I'm somebody that's got no tooth problems, and there will be a time of your life where you have little tooth problems. There will be a time of your life where you have a lot. Mm-hmm. If you're one of those teenagers that had a lot of sweeties, you would know what time in your life you went a lot. I mean, it was in those early high school years. But I mean, Rudy, I go once every 6 months. Mm. The girls book me in. They say, Doc, hygienist appointment.
Yeah.
I said, no, but I'm busy. I said, no. You said you were going to be busy, and you told us to not.
I mean, that's such an important point. I mean, it's like everything. It's like exercise. It's like getting your tests done, everything. There's never time to do it. You actually need to slot it into your diary to do it.
And it's not nice, Shaun.
Yeah.
Okay, do I love going to lie on my back there for 45 minutes and have my teeth cleaned? No, I don't like it. But I do it.
So that's my question now is, if you do have early disease, not advanced disease, but early disease, is a normal cleaning of the oral hygienist enough?
Absolutely. If you have that early stage of gingivitis, and you clean the cause off, which is the soft plaque and the early calcified bacteria, and your measurements are not that deep, just cleaning the teeth, just removing the bacterial layer will solve the problem. But it's like a garden. You weed it this week, it doesn't even have to rain. But if you look again next week, guess what? It's all green again. And those are in your mouth, it's the same. So as soon as you clean the teeth, it colonizes with pioneer bacteria. And as the bacteria gets time to mature, it changes from a predominantly what we call a good flora, a good biofilm, to a bad biofilm. And it's time related. The other thing is not everybody has bad bugs. Some of us have only good bugs and we'll never get the problem. And we're also not genetically susceptible. But other patients, the colonies of bacteria they house are bad. And especially in those patients, they need to go often. So yes, gingivitis can be treated easily and quite inexpensively as well, I might add. It will take you some visits, 2 visits a year to keep it under wraps. And if you listen on how you are taught to clean your teeth and you do that, you should be fine. But if you have the more harmful parts, then it becomes a different story. Yeah.
Just practically, you just said you were taught how to clean your teeth. So you brush twice a day. How many times a week must people floss? Every day?
Oh goodness, am I on the record here?
Yeah. No, I mean,
Yeah.
is once a week enough? Is every day a definite? And I mean, the problem is, again, it's not always nice, so people don't always do it.
Correct. And it's time consuming.
Yeah.
I mean, in theory, you need to clean your teeth. You need to brush twice a day and you need to floss your teeth every day. If you're not a very susceptible patient, you can probably get away with not brushing your teeth every day. But I must say, it's obviously a feel-good factor as well. It's how the day starts with a fresh mouth. The flossing is an interesting one. The Americans had a campaign that's at a big billboard that said "Floss or die." I mean,
Go home.
So I don't think we're quite there yet. But yes, when you floss, there's also. Listen, let me break it down into the brushing. So what's very important with gum infections is that it doesn't help if you brush your teeth. You need to be brushing the tooth and the groove that surrounds the tooth. It's the link between the tooth and the gum. So if you're not brushing your gums, you're going to develop a gum problem. So it's that little groove where you have your nail and your flesh coming together. You have that around your teeth as well. So when you brush, your brush must encompass that groove, which is crucial. That's where the bacteria builds up, where it gets in, where it causes the gum to detach from the tooth. So important, not a scrubbing motion linear in one line, okay? A little circular motion. And you must basically massage that groove. That's what it boils down to. If you can't, if you don't have the dexterity to do that, you must invest in an electric toothbrush. But again, it's an electric toothbrush that must be used as an electric tooth and gum brush. So crucially, very important, that groove needs to be brushed. And if you floss, and if you just go through with floss between your teeth, yes, you're going to prevent tooth decay, but you're not going to prevent gum infection. So very importantly, you need to pass that floss through, around the tooth, against the tooth, and you must go with the floss in that sulcus to floss it. So yes, that becomes time consuming. And if you do that and you find blood on your floss, the biggest thing that patients say, "Doc, I'm glad you're here today. I've been brushing my teeth. It bled, so you'll be happy to know I stopped brushing it." That's the worst thing you can do. The bleeding is your body's way of telling you, listen, there's an issue. I want more cleaning. And if it doesn't sort it out by cleaning more and better and deeper yourself, it's your body's way of telling you you need help. You need to go and see somebody professional. So there's also the stigma where the patient comes in and say, "Doc, my gums have receded. My dentist have told me that I'm brushing my gums away." Then you look in the patient's mouth and you've got thick bacteria over the teeth. Why? Because the patient was told not to brush there. then you will develop a problem. So yes, you must brush those areas, but carefully and correctly.
Okay.
I don't know if that answers your
Yeah, it does. It does. And then I've got a follow-up question. So adjuncts, mouthwash and all those things, do they make a difference? Do people, because you've got the TCPs, that gargling, and then you've got the Listerines, and is it, where do they fit?
I'm not a big mouthwash person. There's specific indications for mouthwashes. Your high caries incidence patients, your patients that gets tooth decay, those patients, important to use a fluoride mouthwash. And this opens a whole different kettle of fish. There's a big move against fluorides for different reasons, but for all practical reasons. If you've got a tooth decay issue, you need fluoride. If you don't use fluoride, you're going to lose your teeth fast. So a fluoride-containing mouthwash for those, with a fluoride-containing toothpaste. But it's the mechanical action of the brushing. It's the mechanical cleaning of the groove. It is not what is in the toothpaste that prevents your tooth decay. Yes, the fluoride does, but your gum problem is not prevented by a mouthwash. And if you use a mouthwash, if you've got very deep pockets, so for instance, you've got severe periodontal disease, mouthwash will be helpful to dampen down that amount of blood and inflammation, but it will not treat it. That whole biofilm that sits in the groove around the teeth that's colonized, that needs to be removed. A mouthwash doesn't do that. So mouthwash can actually give you a false sense of security. It can take away that little bit of inflammation, but what happens deeper and lingers there needs to be cleaned off. So a mouthwash cannot penetrate more than 2 millimeters. In a deep, loose, infected pocket, maybe 3 millimeters. Okay, but then it's severe. I mean, the gums are then moving and flapping. So the fluoride-containing mouthwashes, and then the mouthwashes that's designed with antibacterial effects. And your classic one is there, the chlorhexidine digluconate, which is your Corsidol, Parox, Meridol, these types.
But obviously, you don't want the general population to use that, because then they're going to kill the good bugs as well.
This is
so that's needs to be prescribed by someone like yourself. Say, you've got the problem, we've identified a problem, and it might be helpful in that case. But you don't want that as a general rule for everyone.
But yet the general population goes and buys mouthwash in abundance. And it is a feel-good thing. Okay, so for fluoride-containing mouthwashes, yes, definitely got its place. In the treatment of gum problems, we do use mouthwashes at certain stages. But if a patient has a gum problem, Shaun, or gingivitis, we clean the teeth.
Yeah.
Okay, giving a mouthwash doesn't clean the teeth. It needs to be professionally cleaned.
Yeah. And the fact that they use the mouthwash to make their breath smells better actually shows that they should go for the cleaning and not use the mouthwash.
Yeah, and the big thing with mouthwashes is it discolors your teeth. All of them does. And in a way, then all you need to do is you need to go to the dentist so they can polish the teeth, and that's what you need from the outset. So yes,
creating work for the dentist.
Mouthwashes has its place, but Shaun, I'm not a very big mouthwash advocator. At certain stages after surgery, and I want to emphasize, at certain stages after surgery, we do use mouthwashes. But the treatment of gingivitis and periodontitis is not based on the use of a mouthwash. It is an adjunct, yes, at a certain phase of treatment.
But it's almost one step before you. It's actually more the dental hygienist. If you do that enough, then you can prevent quite a lot of it, if I understand it correctly.
I'm going to take a lot of food from my dental colleagues' mouths, but yes, the important person here and the gatekeeper is basically the oral hygienist. And fortunately we have amazing oral hygienists in South Africa. They are pretty much everywhere, and I think far more accessible maybe than a dentist. But yes, that is at least, if you don't go and see the dentist every year, at least go and see an hygienist. And if the hygienists are trained, I mean, they will see and say, listen, there's a bigger problem here. You need to upgrade now and see somebody like a dentist. And a lot of dentists have an interest in periodontal health. A lot of dentists don't, and they've got more an interest in your fillings or at different compartments of of dentistry. But then they can also refer you on to a periodontist. And not everybody needs a periodontist like me. I mean, our work is basically reserved for the more serious gum problems as such.
Yeah.
So
So the message is we need to slot that into the diary every 6 months or so. If they see you and see there's no problem whatsoever, maybe then you can go once a year. But if there's a problem, you might even go more often than the 6 months. So it's like the colonoscopies. If you had a normal colonoscopy, then you've got a longer time that you need to go. And if there's something that they picked up, you need to go more regularly. I think it's a similar thing with the screening of the mouth. If there's things picked up, then you might increase that visit time.
And that brings me to the next question: is colonoscopy? Our previous podcast was about colonoscopy, and 40 is now the new 50. So we think it's earlier. Where do we start with the dental hygienist? At 5, at 6, at 15, at 20? Where do you? Because to get a child to sit still for that is difficult. So where would you say our listeners must? I mean, they must have a plan. So maybe say when they at university they start, or high school, or
I mean, I think a good way to work that out is to look at who's in your family. I mean, has dad got all his teeth, or did he always have terrible teeth? And did mom or dad lose their teeth, or grandma lose all their teeth with dentures? There's your sign of a genetic predisposition.
I love it. We see it so often in what we do. Exactly. And that is the answer.
So there's not a one size that fits all. So look at the grandparents, look at the parents, and mom, which is again that gatekeeper in the house, said, listen, I've had a gum problem. I mean, you better, let's go and have it checked out. And for a child, some of them would develop, I mean, and boys are ruthlessly horrible when they have to brush their teeth on and on. So yeah, you again, just look at those pointers with the bleeding on brushing. Look at who's in the family, and work it out. Not everybody, not every household in a family of 6 people can afford to go and see the hygienist every 3 months. I mean,
but in your practice, at what age do they usually end up at you?
Shaun, it's not an age-related thing, but age is an issue. It's a time-related thing. So the longer the bacteria accumulate and that it's not cleaned off, the bigger the chance for a problem in a genetically susceptible person. So fortunately, we see very few children with severe periodontal disease, but there are conditions, specific conditions that makes patients prone for that. And if mom and dad had both lost their teeth due to gum disease early, the chance that child is affected is good. But usually for the, let's call it younger than 14, not very common at all. Okay. So in my practice, a very small proportion of patients in that younger than 14 group. Yes, there's other things that we do as part of periodontal services, but not so much periodontitis. Yes, gingivitis, but those patients predominantly go and see the dentist. They would have had their teeth cleaned, and they would have been identified to have an early onset type of childhood periodontitis. But I would say, let's say, when you start to get your first job after you finished with university, when you get that first salary, where you establish yourself, go and make friends with the dentist or hygienist and get into a system. And they should box you. You would say, okay, listen, you are a 6-month patient. I'll see you in a year, or I'll see you every...
So this is the compounding interest type of thing, because if you invest in the cleaning early with your first paycheck, it's much cheaper than replacing them 20 years down the line.
Yeah. But this is another thing with periodontal disease. It's a very slow progress, very slow. So if you ask the question, how long does it take to develop it? It's slow. So say, for instance, you come and see, and I get that so often, somebody would come and see me with a gingivitis. I would say, listen, let's just clean your teeth. And as I say, they think, no, Lochner doesn't know what he's talking about. And I see those patients 5 years later. 5 years later, it progresses. Okay, it gets worse. But what is so amazing, in some patients, it progresses so slowly that we basically do 5 years later exactly the same type of treatment. We clean the teeth, but for some patients it progresses, that there's more intensive cleanings that's required. So yeah, fortunately, it's predominantly a slow disease, unless there's other systemic health issues. For instance, your diabetics, your patients that's immune compromised, patients that's immune system are compromised, their periodontal disease progress in severity faster, far faster, and they also lose teeth quicker.
It's so interesting that this part of your body that you don't really think about, but you brush your teeth twice a day, maybe 3 times a day, and it's actually becoming such a big part of living that and I mean, for us now, it's come on our radar because of all the research we're doing, real longevity, and yeah, we don't actually think about it enough, I don't think,
in general health in our sphere, we don't think enough about dental health. It's not a part of the screening process as such. It's and I think it's definitely something that we need to, speak to people about and say, listen, do you go for your 6-month checkup? Especially, I mean, if we take it back to right at the beginning where we said all these associations may be causal for cardiac disease, dementia, and things like that. And we know a heart attack in your 50s started in your 20s.
Yeah.
And dementia started in your 40s. So these things develop over time. And obviously, this is exposure to the organisms and the inflammation over time. So if we can just step back a little bit, we might even have an impact on the other diseases.
Yeah, so basically what happens is these grooves that I was talking about around your teeth, these pockets, it's a direct passage into your bloodstream. In that little groove is a very, very, very rife little blood supply. And the bacteria that sit in that groove, all the toxins that they excrete are absorbed in that crevice, and it goes into the bloodstream. Very fine. I mean, I can't remember the exact figure, but they compare it to a rugby field worth of surface area. If a patient has his whole mouth, just if you work out the surface area that's in contact theoretically with direct blood supply. So this stuff is crazy. It goes right into your system. And so bacteria directly, the toxins directly. If your immune system is prone, or if you are genetically predisposed, then that hyperinflammation with the cytokines and everything in that very, very vascular area goes directly into your blood system. So yeah, the big ones for me are the cardiovascular patients, the pregnancy related, so low birth weight and premature births, and your diabetics. Those are probably your main ones, which if you think of the population are, I mean, there's other horrible things as well, but those ones are the predominant ones. And there's, especially in those ones, research is unequivocally clear with a cause and treatment related outcome. So basically, if you put 2 groups of patients in and you clean pregnant ladies' teeth, they will have less low birth weight babies.
That's absolutely amazing. Yeah. And what you mentioned, you've mentioned people from different ages. I mean, pregnant ladies or young people.
Yeah.
And then the other diseases might be young or old.
Yeah, your diabetes patients. So diabetics, for instance, diabetes, your diabetic control is better if you've had your periodontal disease treated. You'll need less insulin. You'll need less medication as well.
And if I understand it correctly, so you've got a close association with the bloodstream, but it's not in the bloodstream. So let's say you have a tooth abscess. You will use antibiotics to treat this, but if you use antibiotics, it won't get to periodontal disease. So have I got that correct?
Yes, and there's thanks for prompting me on that one. So what basically happens in the pocket, let's say you've got periodontal disease, so when you brush your teeth, your gum bleeds. So you basically have a ulceration. You basically have a communication from the gingival crevice or the probing sulcus around the tooth direct into the bloodstream. Okay. But yes, very common if you are going to have a knee replacement or with your brother, a hip done or something, they would tell you, go and have your teeth sorted. I wonder how they know that. They probably talk and listen and smell a little bit as well. But orthopedic surgeons, that's a no-no. If you've got a tooth abscess, sorry, we're going to postpone.
Yeah.
So a periodontal disease is as bad. It's actually bacteria that colonizes the inside of the heart, the endothelial component, with these atheroscleroma. So atherosclerotic areas. Sorry, my voice is leaving me there. So yes, you've got micro ulcerations and it goes directly into the bloodstream. But for instance, with a tooth abscess, you've got let's say a reservoir full of pus, dead bacteria and cells. But in a periodontal pocket, you've got a biofilm. So a biofilm is not only one group of bacteria, it's colonies of different bacteria that live together, good ones and bad ones. And if you don't remove the biofilm, if you don't get that groove clean and remove that visible tartar, then the infection will stay. And that can only be done mechanically. So
yeah, because your penetration of the antibiotics can't penetrate the organisms in that.
Because it's a biofilm. And how I explain that is if you look at a pipe, a PVC pipe, and you look at the pipe and you see, goodness, it's green in there. Let's get it nice and white and clean. And you throw J's fluid in. It will make that green bacteria brown. And a day later, it will all be green and back again. You have to literally put a steel brush to it or brush and mechanically brush it away until you've got a clean surface. So this is the problem with antibiotics. It will clean or it will kill the outer layer of bacteria. But on the day the antibiotic is stopped, it will not have an effect anymore. And it's immediately colonized with the safe bacteria. Yeah. That's why the treatment of gum disease or periodontal disease is not, let's just take a course of antibiotic. Yes, in the acute phase, if you've got a periodontal abscess, if you've got a swelling of the face with a fever and and you're feeling unwell and that facial swelling, yes, antibiotics is helpful. But for the treatment of periodontal disease, it's always mechanical cleaning. And in severe cases of periodontal disease, yes, we do add then antibiotics.
Okay, and that now links me a little bit to another thing that's coming onto our radar, and that's gut health. So there you feed the gut different things, and food. Does food change the inside of your mouth? If you eat a lot of sweets, or can you eat something that'll make it better or worse, or is there no association? It's literally you have to clean it.
Well, I'm not so sure if sugar alone will cause periodontal disease, but in patients with diabetes, if the sugar control is poor, their diabetes will be worse. So there's a little bit of a link there. Obviously, a lot of carbohydrates are cariogenic. It causes tooth decay. But yes, there is a little bit of a link with obesity. Okay, and the type of bacteria that colonizes the mouth in patients that are obese, but that has got more to do with that path, with the insulin intolerance as such, and that pre-diabetic type of cascade, which you guys know a lot more of. So I wouldn't say yes, a direct relationship to sweeties, but there is definitely a link for certain patients with certain problems with that.
Yeah. No, thanks for clarifying that. I think, and I think for the people out there, I think we need to stamp down and say you need to get your teeth cleaned with this. So that is the main way to not get periodontal disease. But I think the other side is, we screen for so many things, but this is actually put on our radar massively. 90% of people have this. I mean, that's massive.
But fortunately, only 10 to 15% the severe variant of.
Yeah.
But if it's left alone and left undiagnosed and untreated at the early stage, it becomes more difficult. You're going to have to spend far more resources to get it under control, and you would have already been subjected to that hyperinflammation, which is not good.
Now, so, I mean, the message is clear. There's enough evidence that the association with medical diseases is there. So if you want to think about longevity, if you want to be a kick-ass 80-year-old, you want to do everything to prevent dementia and heart disease and all these things. 6 monthly visit to the oral hygienist or the dentist is a good starting point. And the reward that you can get from that is massive.
Yeah.
A simple action can have a massive effect later in life. And then they can pick it up if it's more aggressive early, and then you guys can come in and sort it out. And hopefully you keep your teeth.
This is the important thing. You keep your teeth. I mean, what is dentistry for? We want to have healthy teeth. You want to have your own teeth. If you have to lose one tooth and replace it, how much that costs? Then and you have a lot of these teeth in your mouth that you start off with, they're free. So all you have to do is keep them there.
The first and the second set of teeth.
So yeah, it's actually such a huge investment. And don't think that tooth replacements are without issues. I mean, patients that have periodontal disease or had periodontal disease are susceptible to have problems around their prosthetics as well. Let's call implants. Implants can have negative outcomes long term as well in patients that are susceptible to periodontal disease or has active periodontal disease. And life also happens. So your mouth can be fine now, but in 10 years from now, not so good anymore. I mean, life happens. You don't look after it so well. You're stressed. You start to smoke. Your diet is not so good. You become unhealthy. And it's a multifactorial problem, like with all the things that you see as well. It is really, and periodontal disease is not a one bacteria issue. It's a multifactorial issue. Susceptible genetics, bacteria, if they're bad, then a lot worse. Susceptible patients. And then there's so many shared risk factors. Like with all the diseases that we've listed over here, cardiovascular disease, the link with smoking, the link with cardiovascular disease and bad oral hygiene or periodontitis, smoking, diabetes, all these multifactorial recipes. And the more negative things you have, the bigger the storm.
Absolutely. I love it.
Yeah.
So, and maybe a last point. So if someone has a first contact with you, so they haven't screened a lot and you see their mouth, do you sometimes refer them back and say, go and see your GP? This looks like something that could be systemic. Or do they normally end up with you after knowing most of the other stuff before?
Yeah, so listen, that opens a difficult, not a difficult discussion, but what we're busy with here, the discussion has actually got a name. It's called periodontal health. I mean, it's become a discipline and an interest for a lot of people to put the link between your systemic health and your oral health together. So, for instance, if I would see somebody in my practice that doesn't fit the normal profile of what I would expect to have a patient with periodontitis. So, a young, healthy person, if they open their mouth and they've got rife periodontal disease, it shows me that there's some extra investigations that's required. And something that's huge is, number one, is diabetes. Okay, so you obviously, you can do HbA1c for that. The other standard of care that I do nowadays for these patients, I look at their vitamin D, the oxidative potential of these patients, oxidative stress. I mean, that cuts across the line in all these hyperinflammations. Iron is absolutely huge. Iron deficiencies. How often do I get a patient that says, "Oh, doc, did you have a blood test?" "Yes, I had." "So what did they look at?" "No, they looked at my iron and they had a HB done." It's absolutely meaningless. You have, you have to have an iron study to look at the whole range, the saturation, the ferritin. You have to look at all of it. But with a lot of respect towards medical practitioners, they only look at the HB, a little finger prick, I suppose, on a. So yes, so those. We look at the diabetes, we look at the vitamin D, we look at the iron, very importantly, also at the B12 and folate, because with anemia, you get iron deficiency anemia, B12 and folate. You can have, and it comes with gut health, your folate, which is often the issue. Okay, so different types of anemia. And these patients that is anemic are poorly oxygenated. Their tissues are prone to infection because the oxygen, in layman's terms, there's not enough oxygen to help. So they're poorly nourished and they have worse gum disease.
Yeah, that's quite interesting. We do quite a lot of iron infusions, and we've had Professor Vernon Lowe on one of our previous podcasts about iron.
Okay.
And
I should listen to that.
Yeah, it's very interesting. And I think this now brings in teeth as well, because we talk about hair loss, brittle nails, but we never made the link between teeth and iron. And we see a lot of iron deficiency. And actually, when Professor Vernon Lowe, he said iron deficiency is actually the most common illness in the world, except if you ask the dentist, they will say periodontal disease is that is actually how he started.
Did he say that?
Yeah. Good. So it's actually quite interesting.
I'll see him at Vleespaal. I have to ask him.
So, yeah, interesting.
Yeah, wonderful.
Very interesting.
Yeah, and then obviously a full blood count.
Yeah.
That will rule out the really bad things.
Nice. That was so informative. And I definitely think we're bringing this into our report. We have to
absolutely.
We have to at least touch on when last have you seen someone for your teeth. Yeah. Thank you so much.
Thanks for coming.
Goodness, that was quick. Thanks, guys, for having me. I hope it answered a few of your questions.
Yeah, absolutely.
Yeah, and as we said before we started, you think it goes slow, and then suddenly an hour has gone past. It's It's nice to have you here, and thank you again.
Pleasure.
Yeah, so we'll just link your details on the podcast, and then people can reach out to you if they've got a problem.
Thanks, Shaun. Thanks, Rudy.
Thanks so much.
Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.